you may not have printed it, but you may have read it. It is described really as the let's start here list. So we didn't have an enormous amount of time to develop it. And when we got into a lot of the detail, what became clear is that there is a great deal of change that is needed for our system to really meet the needs of our community, support our workforces, and recover from many years of sustained underinvestment. And those things are beautifully outlined in the health system review run by Heather Simpson. So what we'll do is I'll just run through a really brief overview. I'll flick through some slides. There's slides I can send to Grant and he can distribute to you. And I apologise for the slightly bumpy start. I spoke to Grant last night while he was having his dinner because it was in my diary for last night. And I've just popped out of a 21st birthday party, which I'll pop back into after this. But it's a real pleasure to be with you tonight and to be able to talk to you about the plan and answer some of the questions that you have. So hopefully people can see the screen. So Te Pae Tata as an interim plan is a sort of guiding plan for the system. The future full New Zealand Health Plan will be a more comprehensive view of what we are delivering for the people of New Zealand. And in the future, it will be a plan that is across the whole delivery of the health system, not only Te Whatu and Te Aka Whaiora as this first plan is. It's also a plan that should be supported by iwi Māori partnership boards and locality planning in the future and guided by the interim government policy statement, both of which are in development, so weren't available for the formation of this plan. It's built on 4 platforms. Firstly, delivering equity for all people. There is a particular focus, which I'll go through shortly. Embedding Te Tiriti o Waitangi, implementing a population health, and ensuring the sustainability of the health system. And those 4 domains are embedded in the Paiora legislation. Equitable outcomes for New Zealanders is a major driver of this plan. People ask us why the focus from a population perspective is on Māori health, Pacific health and tangata whaikaha. And so they're identified in the legislation as having priority. Māori health, of course, Māori equity are right under Te Tiriti o Waitangi, and something that Y2575 claim clearly outlined that we have not met our obligations to Māori. Pacific health, who've had sustained and persistent inequities that have not been addressed by the system. And for tangata whaikaha, and I was reading some media releases and their literature and communications over the last couple of days. This is the first health plan for disabled people that has ever been developed by the New Zealand health system. We do a lot of disability support services, and this is the first time we formally recognise that the health of disabled people is an equity and a right as well under the UN Convention. Throughout the plan, we identify where people live. So rural communities are identified as a significant community. Ultimately, of course, it's about equity for all New Zealanders and amongst all New Zealanders, and that will become part of the system that we are creating. So you'll see here that we talk about creating equity for all. We are starting with priority equity action areas, which is Paiora or better health in our communities. That's really about those things, the population health things, the early interventions, the lifestyle things, the mental health and wellbeing work that currently is quite siloed, coming together. Kahutorema, which is our maternity and early years focus. Mate pukupuku, people with cancer. Mawiri Tomaha, which is our chronic health conditions. And of course, our oranga hine naru. And all of this is built on a premise around people. And one of the things that's clear that workforce is a major issue. We have the workforce task force. They have priority groups that they are working to develop solutions for and with. And one of those is the rural workforce. Making sure that we listen to and take heed of the voice of consumers and whānau, not only in how we measure that, but also in how we deliver that. And interestingly, to the right, we talk about our inclusive leadership and culture and the diversity. We cannot expect people to value the hearts of the people that we serve. We don't value the workforce and create an environment in which people feel valued, included. So the plan does talk about words like bullying, It talks about discrimination, and it talks about those on purpose. And in my 35 years of the sector, it's the first time we've been able to talk about those things openly and how important it is that we reset the system. And insights and intelligence that's about people. And that thing about people is critically important, about knowing how people journey through our system, understanding their outcomes, understanding the inequities in the system. And one of the things that I know you're aware of is changing the rural coding system so that we can better measure and monitor rural health and get ourselves out of all the debates of what's rural, what's not rural, where does it sit. So these are just describing those priorities that I've just talked about. Paiora is a really interesting one, and particularly it has a well-being focus, and health is quite strongly fragmented in this space, and bringing that together. So suicide prevention, mental health and well-being, your personal physical health, and what we do to support that, whether you're having babies or whether you're older, being part of a community-centred locality approach. And locality networks, we have a significant role in this space. Maternity and early years, highly fragmented services, significant variation across the system. Health is not seen as the easiest system to engage with for people. We have identified that rural healthcare access in maternity and early years is a significant issue. So building new models, changing the settings so that we can take away artificial barriers like the 6-week handover, create integrated models and support workforces and communities beyond midwives who are having to often work alone. We know that there are communities where they work alone, making sure that we can wrap teams around them, that we have the funding to do that, that we can support people to be part of communities that are caring for whānau as they grow and their families and as their families are thriving. Cancer, a number of issues in here. One of the things the plan talks about is access to transport and accommodation. With our starting place is cancer. We have identified that your right and your ability to access support, if you're coming from out of town, out of a major metropolitan area, is hugely variable, sometimes very complex or mostly very complex. And what we know is that Māori and Pacific and those communities are the least likely to obtain support through that system. So the program is to start with a project in cancer as the first place to ensure people can access their cancer treatment and complete their cancer treatment and get the transport and accommodation that they're eligible for and learn how to make that a simpler system. Chronic health conditions. This is proving to be, it's quite a challenging space, of the fact that there's actually not as much agreement as we think there is about what's important in this space. So the creation of nationally consistent clinical services is really seen as the first step in this space. The supporting whānau to live well and healthy lives is connected to Paiora, but that first step towards reducing variation, which, as you will all be aware, was a major Prime Minister and Minister promise from the health reform. We don't call it the postcode lottery anymore, but that we remove that from the experience of people over the next few years. And then our mental health system. There's, of course, Haiara Oranga, which is the plan in which we are investing in mental health services. But there's also a significant focus here on how we connect specialist mental health services, mental health NGOs, primary care, community services together, and support those to work together inside localities. And of course, in our rural communities, this is often where the services are absent or services are less accessible, and how do we change that? Talked about the Māori, the equity groups. So I want to talk a little bit about rural healthcare. It is a priority in the plan. It's recognised as an underserved population, which you will know much better than I. We've established a primary community and rural early actions work program, which is working through a number of early issues, and we'll be coming out to talk with yourselves and the wider sector from the end of this calendar year. So we're just putting work together to bring that out to you and talk to you about it. The acknowledgement that the workforce is under enormous pressure is really clear, and our workforce task force, part of coming out to work with you, at the end of this year will be about working through the solutions and options in that space. It is a government decision around some of these areas, but there is much that we can do to support development. And also the development of the rural health strategy, which is led by the Ministry of Health and is developed as required by the Pae Act. A little bit like this is the first health plan for disabled people. It's really exciting that a rural health strategy is being developed to support these communities. So look, that is a rapid fire run through because I know you have a lot of questions, and I wanted to just give that overview so everyone sort of understands and a little bit of insight into what we are doing in this space and what the purpose of the plan is and the intention of the plan. So look, I'm happy to stop there and take a breath and start to go to questions. Grant.
Thanks, Rachel. I just need Marie to start my video. There we go. Cool. Hey, thanks very much for that presentation. I guess we've been waiting quite a long time for this interim health plan. It's sort of been promised month after month, and when it's arrived, there aren't really tangible goals or outcomes in it. So, I mean, the first question is, how will the Te Pae Tata, within its 18-month to 2-year timeframe, enable us to significantly improve health outcomes? What's your response to that?
So one of the challenges when you're writing a health plan like this that's never been written before is it fulfills two different services. We write health strategies all the time. I say to people that when I retire, I'm going to write my PhD on the health strategies we did not deliver on. And we've had reforms after many. Te Pae Tata is an action list, is something that we are required to deliver on. We're accountable to government for all of the actions that are through this plan. So that's never happened before. That was a major change in the Pae legislation or the Pae Act, the Healthy Futures Act. So we went through and developed those things that we saw as important markers to progress the system. So there are some things that are about data and digital infrastructure, changing how we collect data. There are some things that are about workforce. There are some things that are about mothers and babies and getting access to cancer treatment. Everything that's in there, we have to have made progress on before the 30th of June 2024. So when we were writing it, people would say, well, we should write this population health, outcomes-based set of aspirations. But that's not the purpose of the health plan. Those things are really important. And as we get better and better at this in future years, I see us moving to a place where we will have clear measurement. But this plan is about setting the baseline, getting started and shifting a system that has never been a unified health system in partnership with Te Tiriti. There will be gains for individuals and for healthcare service access, with the formation of different services, which you can see throughout the plan. There are things that will be commenced. I was working today with the team on the intersex development of resources for the intersex community so they can access primary care in a way that is safe for them. That's incredibly important, but it's a whole range of activities. So hopefully that answers the question.
Yeah, thank you. I mean, during your presentation, you talked about the early actions work program for rural. Are you able to share what some of those early actions are going to be?
So we're coming out the end of this month or early in December to talk about the range of actions and what we want to work with people on. There is a focus at the moment on working out what we can do, but there certainly has been a commitment to how people can access services after hours, comprehensive care teams and how they support communities. So it's in that place that it will be working in that program. A priority is being given from an equity lens to our Māori Pacific communities and our rural communities. And many of those communities overlap, of course, inside. So we'll come out more formally with that.
Okay, thank you. One of the questions we have here is the fact that in July, we all attended a workshop just up the road beyond Parliament where Te Whatu promised us within 6 weeks a rural after hours telehealth service, and we're still waiting. What's progress on that?
So there is significant progress being made on ensuring that we have a solution that works for our communities. It was probably ambitious for the people who promised that within 6 weeks, and certainly that time frame was not achievable. That was before my time in that program, but certainly I know as I spoke to the team today, it is a major priority to have a core service up and running before Christmas.
Before Christmas, okay, thank you. A couple of questions on localities, which is a pretty key issue, because in Te Pae Tata it says that communities will be able to self-define, if you like. To what extent will we as rural community members be able to define our own rural localities?
So one of the things that's happening, the locality team is working with the pilot sites. So there's about 12 of them now, I think, working with leaders from those communities, talking about who's at the table, how people are engaged, how mana whenua are engaged, how community leadership is engaged, to start to define what those communities are. So there certainly is a place for a voice, and that's why it will take us we're aiming to have our localities fully established by 30 June 2024 as we work through all of the variables really for communities. But certainly as someone who was part of establishing that within Te Pae Tata and within the legislative framework, it is intended that they're communities that people identify with. And that people understand. They will, of course, have a lens over them about where are their natural boundaries, how do they relate to mana whenua boundaries, how do they relate to community boundaries, and the number sort of has an expectation around the 70 to 80 mark with our 15 iwi Māori partnership boards. So that will happen inside each community.
Okay, there's not much information about how localities will actually function. Question here, how will they be empowered to improve rural health outcomes? And what are we going to see that is different to current approaches and leverage off what we are currently doing well?
So it's a locality approach that means that what we're doing is seeking to shift into localities or into communities the ability to identify the health services they need and how the health services they have operate now and how you close the gap between what those two things. It's supported by nationwide processes that are designed to support that planning process, to ensure that people have the information that they need, that they are setting those priorities themselves. It is certainly the expectation of the legislation and of the minister that locality plans are developed by localities and then agreed by iwi Māori partnership boards as part of that process. So I think it is something that will evolve. Of course, we are starting to do things already, so to start to prepare for localities, but also to progress the improvement in services where we need to unpack things nationally. That people are ready and funding can flow into localities.
Okay, a lot of people here. Sorry, carry on, Rachel.
Just a comment there about locality approaches are different to clinical or to practice networks, or provider networks. And I think they often get confused. There's just a question here about how you set up a locality without a general practice. Localities are communities of interest. They are not built around health services. So provider networks, which is the next big piece of work that we'll be doing in the first half of next year, is how are provider networks developed to support localities. So that's just important. And pilots for localities were chosen through a submission process prior to the establishment of Te Whatu and Te Whaiora prior to the 1st of July. And it was really about people who were already starting to work in that way and could be early off the blocks. So.
Thank you. One other person wants to know if localities will employ staff.
So it's an approach rather than an entity. There will be staff who support localities to have the leadership that they need, to have the storytelling and the analytics that they need, to be able to make good choices, to develop those plans. And they will be support entities that make sure that localities are robust. It won't necessarily be one set of supports. People may be supporting a number of localities who are close together or similar in type. but they will certainly have the resources that they need to actually be effective.
Okay, let's switch our focus now to midwifery maternity. It was one of the slides that you put up during your presentation. How does Te Whatu envisage the proposed health system reforms will support communities to have equitable and sustainable access to rural maternity services?
Yeah. So there's a particular area of access action in Te Pae Tata called kahutaurima. Kahutaurima is about the cloak that wraps around our families as they are growing and creating themselves. There is a really clear intention in there that we will develop more team-based approach and the ability for teams to form within communities and localities with a wider range of workforce. There is also funding attached to that for Te Māori and for Pacific models. We're also unpacking some of the funding at the centre. So there's certainly a lot of work that's being considered in that space, and there'll be more coming out about that later in the year. But again, we're not coming out with all the answers, but we're coming out with the ability to change the way in which care is delivered. There's a lot of work being done by the Workforce Task Force on how we can support midwifery and how we can make it more sustainable. But part of that is also about the employment models for midwives, because currently it's almost very binary. There's been some really good success in the South Island and counties Manukau and Porirua, where community employed midwives are much more sustainable models. So there's a lot of opportunity in that space, and it is a major priority for us and Te Aka Whaiora over the next 18 months.
Okay, thank you. In terms of facilities for maternity, has any intentional consideration been given to the distribution and location of rural primary care maternity facilities as part of the rural hospital infrastructure?
So Te Pae Tata references that we need to get really good at planning our networks, our settings of care, which includes our rural maternity units, our hospitals, our rural hospitals, and going up to our major hospital networks. I had an interesting conversation in Taupo the other day. We launched Te Pae Tata, and they were talking about how they wanted to be part of their rural health network rather than part of their hospital network. But we have identified that that is a priority for planning so that we are in a position to make stronger decisions from 2024. Because there currently isn't a plan. I think the last time they tried to create a plan, they published a hospital plan, was 1997. When they published a network plan. So that is part of the new model.
All right, watch this space.
Mm-hmm.
In the mind of the agencies, are rural primary maternity facilities and services considered part of the hospital and specialist services or part of primary and community services?
I think that there's always a hook in a question like that, but certainly the example that I just hook in the sense that there'll be small places and bigger places who have different needs and different expectations who might identify. But certainly the example I gave from Taupo is the focus is on how we build local approaches, bringing people together in communities rather than artificially attaching them to places where they might be referring patients or managing patients. And particularly as the practice of rural medicine grows, and we see more and more rural medicine specialists and more nurses and clinical professionals and midwives working in those rural communities, we see that as critically important to bring those networks together and support that as rural healthcare rather than think of it as an outreach of a hospital, for example. So that will be part of our thinking going forward.
Okay, let's move on to workforce, because every time we turn the news on at the moment, there's another crisis somewhere in health, and rural has its fair share, and you alluded to that yourself in terms of a real shortage right across the health professions within rural. How is Te Pae Tata and in fact the agencies, what are their strategies for dealing both short-term and long-term with rural workforce?
So the Workforce Task Force is doing a lot of work in across the space with regards to unlocking what some may seem as simple solutions, but also then working on some of the harder pipeline solutions. I don't have those in front of me. I'm sort of aware of some of the work that they are doing, and the Workforce Task Force will be coming out more and more and working with people. I see on the screen there's a question about funding and bonding for rural midwifery students. Certainly that's some of the conversations that people are having. How do we create a rural practice as a place that people find really attractive, that they're drawn to and that they're able to participate in? There's big conversations about does bonding work, but certainly the concept that we need to create really positive places for people to work, but also support them to stay there, to be part of communities and build that workforce is recognised.
So we understand that there are at least 6 workforce pipeline sub-task forces being formed, one of which, for example, is a medical one around midwifery, etc. How do we get rural input into that? Because there are very few, if any, rural people on those sub-task force groups, let alone the major one.
Yeah. I will come back to you specifically on that, and certainly we work with Elsa Clare, who chairs that task force, and it's my understanding that a focus on rural as a cross workforce is certainly open for consideration. So I'll come back to you formally on that, Grant.
Okay, and we'd welcome that because we have 9 chapters and we have the ability to get a breadth of input, as you can see from the interest tonight.
Absolutely.
Let's move on to funding, and I want to keep moving through here so there's some time for people from the floor to ask questions as well. What's the process and timeline for the review of primary care funding, including capitation? Because once again, we keep hearing that we're about to hear something about it and nothing comes out. What's happening about that?
There will be some discussion coming out early in December about the timeline for that and what does that mean. We are very aware that we got slightly trapped in this process of so many things being stood up and new senior leaders being appointed, but there have been discussions in the last week, and we definitely will be out with some timelines and pathways in the next few weeks.
Okay, so does that mean before Christmas, we think we'll hear about that as well?
Well, before Christmas, absolutely.
Cool. So one of the slides we were shown in July about early bits of work was about the review of rural after hours prime services. Can you give us any indication of how that work is going?
I can't at the moment, but certainly we will make sure that before Christmas we give a comprehensive update of where everything is at. But it's certainly identified and recognised as a piece of work that must be done.
Okay. Is there a plan to review the funding of NGO, community and iwi-led rural hospitals, both operationally and in terms of capital investment?
Te Whatu are certainly aware and are very committed to developing solutions for Māori providers and with iwi providers around some of these things. With regards to infrastructure, it has been identified in many conversations that there are challenges there, and that will take a little bit longer to resolve, and that will be led out by Te Whatu, where it's iwi owned and iwi led out. For us, it's for Te Whatu, we do identify it, but there's currently no pathway for resolving that.
Okay. All right, that's pretty critical for many of our rural hospitals who are sort of caught in limbo in terms of both the operational and capital funding and being able to serve those communities.
That pathway is a challenge for all of our infrastructure because it's recognised that we have a major infrastructure challenge in the health system, and we have far more need than we have available resources. But it is part of that pool of conversation.
Okay. And I know that you haven't got all the answers and won't have them all, and they're still being formulated, but thanks for at least fronting and being honest. Another question here is about the fact that various DHBs and PHOs took various strategic approaches to funding services in their regions, and some were more generous in funding rural practices and hospitals, etc., than others. How is Te Whatu Ora going to ensure that resources are equitably distributed across localities and regions going forward?
So this is one of the fundamental premises of the reform, is that we remove variation and create fairness and equity across Aotearoa, and that's not a lowest common denominator kind of fairness and equity, which is always a risk when you have these conversations. It will take time. Te Pae Tata identifies that it's a priority for government, it's a priority for measurement, and understanding what's happening with our resources and where they are going. And we have a very clear expectation that we will resolve that. It will take time. Firstly, to understand the extent of the problem. Many of you can understand bringing together 26 organisations with 26 different profit and loss and financial systems. Oh, there's not quite, there's 13 different financial systems, and balance sheets has its own huge challenges. But we are very clear that that is one of the major tenets of the reform, is to create a fairness across New Zealand. And we are being asked also to be really clear about how we understand improvement in equity of access across New Zealand, so that no matter where you live or who you are, you have fair and reasonable access.
Okay, you can see in the chat there's a question about a focus on St John's. Obviously, ambulance services are key to after hours urgent care and emergency services, and where there aren't enough services, then it falls back on general practice because they're last in line in rural areas. Is there any focus in these plans on how St John's and perhaps even Fens are included as a overall holistic response system?
Yeah. Not in this plan specifically, but the important thing is that one of the reasons we adopted the locality approach is because it allows those things to come together in a more sensible way, particularly in rural communities. There is a recognition of the importance of St John and Wellington Free Ambulance and being part of our healthcare system, but it is a tenet of locality. So those are the things that we will expect to be a priority as we move forward into 2024.
Okay, and I'll just pick up on that other question in chat. It's about the we and we will be doing. I guess there's a general discomfort that we've planned for the last 20 years. We keep having plans and strategies, and nothing actually improves on the ground. In fact, often it's worse in recent times, especially with workforce.
Yep.
How can we get to an actual do stuff and make a difference? We'd much prefer to put our energies, and many of us would have clear ideas on what we want to do and now, and put resource there. How do we get to a do so that there's some light at the end of the tunnel?
As I said earlier, and I think it's a really sensible question, by the way, and I also think it's about the fundamental accountability of the health system to the people of Aotearoa. Te Pae Tata and every future health plan under the Paiora Act requires us to be accountable for every action and for deliverables. So inside the plan, there are a number of things that we need to do, which includes addressing health needs as well as addressing infrastructure and working our way through a number of systems. This plan will be the last plan that has lots of plans to plan, because we will only merge ourselves once, and merging yourself is a major entity. It has a major exercise in its own right, in that unification. What it creates is all sorts of opportunities. So it creates the opportunity, for example, the transport and accommodation, which is a small opportunity, but a significant one. At the moment, depending on which district health board you lived in, would determine whether you could get access to supported transport or supported accommodation to access your cancer treatment. That is something we'll be fixing over the next 12 months that we could never have fixed under the previous model. The other thing is that in the plan, if you look under the performance section, it says in the performance section, it talks about the measurement of variance and the key equity priority areas from January of next year. And it says that because we have to start working out how to do it. And that is making sure that we will start to report in those 4 areas on variance and on change that is happening for our communities. again, that's a first for us. We have never had to do that. People who understand health reporting, and you will have seen it yourself, it tends to be very narrow, very specific, largely activity, a little bit of coverage basis. There's no metric anywhere that says what's access or investment or resource, what's happening for people living in rural communities. Or that is one of the primary underpinnings of this plan. So even though it may feel a lot like, and when I say we, I mean Te Whatu we, all of its 26 entities, Te Whai Ora, all of itself, not we who happen to reside in Wellington. But this plan and future health plans are a substantial shift in the accountability of the system to a level we have not ever had before with regards to public accountability.
Okay, well, thanks very much. I see that Peter's got his hand up and we'll give him the opportunity to ask a question. Just a global statement, I guess, Rachel, is that everyone's here tonight because we understand that this is a major reform, therefore a major opportunity, and we want to be part of the solution. But to do that, we have to be able to be heard. And frankly, we haven't felt that we've been heard. So please open those lines of communication, give us the opportunities to be able to put our voices forward and be part of the solution. That would go a long way to making us feel like we're valued, I guess, as a sector.
Absolutely. And that's the things that we're working really hard on, to open those channels as we go into the latter part of this calendar year, so that we can hit next year with a fresh energy and an opportunity for lots of engagement, but also transparency in how decisions are made and what decisions are made.
Okay, great, good to know. Peter, Marie, can you unmute Peter?
Peter, you might have to unmute. I'm trying to unmute you, but
you might have to unmute yourself, Peter. Perhaps Peter put his hand up and went home for dinner.
I suppose just while we're in a quiet moment, there's a couple of things I just like to acknowledge, and I know that you have met with Chiquita Henson, and Brendan Marshall's been part of this work all the way through. They're incredibly strong advocates and leaders in the system who are ensuring that we keep this focus on rural healthcare and bring it right through. And we will see more and more of that advocacy from yourselves and across the system. But I really want to acknowledge all the work that they have done in the last year in bringing this into this place. You'll see more and more of that work coming back the other way very soon.
Yeah, thank you. I'd very much endorse what you're saying. I see Brendan's online listening today, and Brendan, once again, thanks very much. I had the honour of being hosted by Brendan up and down the coast, and seeing the provision and the passion that people put in there in very constrained workforce situations, and they're doing a massive job and have got some really creative ideas. So it's great that Brendan is able to bring those to the table in Wellington on our behalf.
Fantastic. I think Mark talked about how can we help the success, and we are really aware that we have to be out and we have to be engaged, and we have done that, and it's people like Brendan who bring that voice in. But as we move into localities and move into networks and start to set up some of these systems, it's the energy of people like yourself that will ensure our success as a system, because most of our work is about settings and freeing things up so that there can be good shared collaborative working inside localities, and many of those localities of course are rural. So thinking about those relationships across providers, thinking about those relationships with mana whenua, with community leaders, is a really important part of preparing the ground to be able to get to our future. We're in 3 to 5 years' time. What communities think is what's driving how their health services are configured. So the more you can do to do that, the easier it'll be for us to reach a place of success.
Okay, thank you. Jeremy, I note your comment there. I think Marie can unmute you. Do you have something to say? A question to ask? Marie, can you unmute Jeremy? Jeremy doesn't want to say anything, and Marie's muted herself, and we don't know if she is there or not.
Oh, no, I am here. I'm just trying to, as I've explained, this is not my area of expertise. And so I'm just trying to figure out how to unmute people. Round about now, I have, because the group, is keen to talk, it's would be good if I could figure that out, but
well, there's just a question here about will localities cross DHB boundaries. So DHB's boundaries will become less and less. So what we now know as district boundaries, less and less relevant as localities stand up. And as we bring people together across regions and across Aotearoa, because districts in many cases are artificial impositions as well.
Is there any key learning coming out of the pilot localities, especially the rural ones such as Wairoa?
Yeah, relationships, trust, nothing moves faster than trust. Making sure that people are working together. Where people have been working together for a while, they're more confident that they can move into locality planning early in the new calendar year. Where people have not worked together, not sure about each other or don't understand each other's contribution in their communities, where people are new to the table, that is taking a little bit longer.
Okay, and the question is, will this recording be shared? And yes, we will be able to put a link up to the recording after tonight's meeting.
I'd like to ask a question since I've got the microphone.
We can hear
you. Rachel, yeah, you can hear me as usual. Rachel, we're very aware that this is the first time ever we're going to get a rural health strategy. How will all the people online and those that are out in the sector, our 194 rural general practices and 30 odd rural hospitals have input into the strategy? Is there a plan to engage with us about that, and what would the timeline for it be? And what do you expect to achieve out of it, a strategy, rather than being another one that you will put into your PhD as having been written but not achieved much? That's a bit of cheeky.
That was a good one, Marie.
A bit of cheek on the end there.
Go for it. And the thing for us is we don't do the strategy. The strategy is done by the Ministry of Health, but that's something I will come back to Grant on and yourself about their process. We are only inputs and participants. So the Ministry of Health lead that work out, and that is it's a priority for them, and they have to deliver a strategy before the 30 June 2024.
You've talked a little bit about how the accountability's never been bigger, and that the onus is on Te Whatu Ora, Te Akawhai Ora and Maratu Hauora to deliver on the Te Pae Tata and Future Health Rural Strategy. What is not delivering look like to you? What would be the consequence? How do you say, the members on the panel and the webinar can have confidence that that's not just nice words to hear to make us all go home and feel that we've got it sorted?
So there is a thing called an implementation framework that's been developed alongside Te Pae Tata, and that is something that the two chief executives and the two chairs of the boards are accountable to the minister to deliver on Te Pae Tata. And having been involved in the sector for 35 years, we have never had a plan that has had this level of clarity. And I know sometimes people say to me, but some of the actions seem quite straightforward, things you would expect an entity to be doing. And the reason that they're written in the plan is because we then have to demonstrate that they have been achieved. So that is why it is different, Marie, and there will be public accountability against that.
Thanks, Rachel.
Okay. Rachel, and I'd just like to let everybody in the audience know that Hauora Tai Whenua has spoken to Manatu Hauora about the development of the Rural Health Strategy document, and we are going to be fully engaged and will involve you all as stakeholders. And our aim is to have that team present a draft after having our involvement and your involvement at a strategic planning function next March. So watch the space as we work with that team to get as many people involved as possible. Rachel, I guess what we'd like in terms of accountability, is, I know the Minister doesn't like the word targets, but targets are measurable. And in terms of workforce, for example, it'd be great to have some targets that we're heading towards, because then we could actually know whether we're achieving an improved workforce level or not. So you could take that back to Margie and Rihanna. That'd be great to do, and the board of Te Whatu. We'd love to help you achieve, set some rural targets that we think would actually mean meaningful improvement for the health of rural communities in rural Māori.
Yeah, absolutely. And I think that I don't think part of getting prepared for the next plan is working out what we can measure, and so that we've got a pathway to become more sophisticated over time.
Thank you. All right, well, I did promise you that we would stay on time, and you do have to get back to your niece's 21st. So just on behalf of everybody, thanks for fronting tonight. I know that there are some challenging questions, and they will continue to challenge, because all of the participants here are challenged daily in their job. So we will hold you to account, but we're also saying that we're here to help, and please involve us. So I guess we'll close with that. Big thank you, Ko Marie. And if I just close again with karakia to send us on our way, I think that would be appropriate. Kia hora te marino, kia whakapapa punamu te moana, hei horarahi mā tātou I te rangi nei, araha atu, araha mai, tātou I tātou katoa. Ko Maria, everyone, thanks for attending. We'll make this available, and have a good evening.